Hi there, everyone. I want to welcome you all to another episode of our expert briefings. This is the second in our series, so very excited about today's topic, PD and medications, what's new. I want to welcome everyone who's logged in via Zoom to our webinar, and also those of you who are on Facebook as well. It's going to be a great opportunity. As I mentioned, this is our second expert briefing this year. We have 6 that are in total for the year, so there's 4 more coming, so keep an eye out for those. For those of you who are joining via Zoom, I just want to orient you to the screen. At the bottom of your screen, there'll be a couple little boxes. One says Q&A, and that's where you will have an opportunity to ask questions of our speaker today. And our colleagues will go through those questions and make certain that they're appropriate, of course, and hopefully have an opportunity to ask them during the webinar. If not, just keep those questions in mind. We have a helpline, which is fantastic, 1-800-4PD-INFO, and my colleagues there are standing by and can also answer any questions that might come along. In the chat feature, it's a one-way chat, so we will send information out to you. For instance, links on how to download the slides from today's expert briefings and other information as well. So we have the next slide. So just want to, for those of you who may be new to the foundation or maybe not so new, just want to remind everyone that the Parkinson's Foundation mission is to focus on improving lives of those living with Parkinson's, both through improving care and advancing research. It's important to emphasize that everything we do is done in close concert with our community to ensure that our actions are aligned with the needs and priorities of those living with Parkinson's disease. And our next slide, I just want to focus on that, we have 3 main goals that we try to achieve our mission, and that is to advance research towards a cure, empower our global community, and improve the lives of those living with Parkinson's disease. And we're doing that, one way we're doing it is through our expert briefing series today. So if we can have the next slide. I want to give a shout out and a thank you to Genentech. It's a member of the Roche Group. They are proud supporters of our 2021-2022 expert briefing series. And with that grant, we're able to bring this to you today. And also for today's session, I wanted to give a thanks and a shout out to Kiwa Kirin for their support for today's expert briefing as well. The next slide. Just a reminder, we're recording this episode. For those of you who may have to drop off or you have friends who may be interested in what Dr. Hinson is going to be speaking about, our topic today, that will be available in about 1 week to do so. My colleagues, as I mentioned, are going to use this chat feature to give you a link to download the presentation. It's just going to be the slides, so it's none of us speaking, but you can have that as a backup too if you wanted to take notes on it and have the opportunity to do that. So without further ado, let's move on to a poll. So for those of you on Facebook, you won't see a poll pop up like those on Zoom will, but feel free to put your questions in and submit them via questions in Facebook, and my colleagues are standing by to answer questions. So here we've got want to understand our audience. What is your connection to Parkinson's disease? We've got a couple different options to put in there. I'm going to put mine as scientist researcher and go from there. So we'll just give it a few seconds. We've got lots of people who just joined in the last minute or two. So give them an opportunity to participate in this poll. And wow, not surprisingly, a lot of people who submitted in the poll, participated in it, are people living with Parkinson's disease, and a lot of people who have loved ones with Parkinson's disease. Healthcare professionals are on the call. Welcome. Hopefully you'll have some good information here as well. I think the topic is going to be, today is going to be fantastic. So let me now take the opportunity to introduce our speaker today. Dr. Vanessa Hinson is the Director of Movement Disorder Program at the Medical University of South Carolina in Charleston. She's also Chief of Neurology at the Ralph H. Johnson VA Medical Center in Charleston. She earned her medical and doctoral degrees from the University of Hamburg in Germany. She completed her residency in neurology at the Medical University of South Carolina and had specific training in movement disorders at Rush University in Chicago with support from the Parkinson's Foundation. Dr. Hinson's special interests include the diagnosis and treatment of Parkinson's disease, needless to say, as well as research in the field of cognitive impairment and non-invasive brain stimulation for Parkinson's, which is a really exciting area. So I will now turn it over to Dr. Hinson, and I will come back for the help answer your questions with Dr. Hinson. So Dr. Hinson.
Thank you so much for having me. Please confirm that you can see my screen.
We can. You just need to hit the resume slideshow there button for presentation mode.
All right. Okay, I think we lost my presentation here, didn't we? But let me take the time to thank the Parkinson Foundation for having me today. This is an absolutely awesome opportunity to be lecturing to all of you, and I'm glad to see that so many people signed on. I will now go to my slideshow and screen share again. Sorry about that. Are we all good now, Jim?
Yes, so you just need to hit present from the beginning in the upper left-hand corner, and it'll go into presentation mode, I believe.
Oh, that looks so good. I hope we didn't lose anybody over this. So my topic of today's presentation is really important, I think, to all of you who live with Parkinson's disease, who have signed on, and their caregivers and spouses, namely that of Parkinson's disease and medication, and specifically what is new in the field of Parkinson meds. So I put in a slide for you that shows many famous faces of people living with Parkinson's disease. And I just wanted to highlight essentially the diversity of these faces, right? You might recognize all of them, you might recognize a few of them, but what we do know is all that these nice folks have Parkinson's disease, but that they don't look alike. They might not physically look alike, but their Parkinson's certainly does not look alike. And the point of this is to say that Parkinson's disease really is not a single disease. What we mean with that as Parkinson's specialists is that we think of Parkinson's really as a syndrome, meaning that Parkinson's is not as trivial as saying that everybody who has a resting tremor, slowness, and stiffness has Parkinson's disease, and everybody with Parkinson's disease is going to have the same experience that needs the same medication treatment. That is not so. Parkinson's comes in a variety of shades. While there might be some common themes, such as the slowness and stiffness, there are many differences between individuals, as you already saw in the picture. And therefore, the approach to treating Parkinson's and to choose one of these new medications needs to be customized. So what I mean with that is when I say that Parkinson's disease might differ from one person to the other, an example of that is that not everybody with Parkinson's will ever have tremor. About a third of folks with Parkinson's never have tremor. And isn't tremor one of those things that we all take for granted when we think about Parkinson's disease? Another issue is that, for example, those folks with tremor tend to have a slower rate of progression than folks who present with a rather more stiffness predominant form of the illness. Those who fall earlier, have earlier walking or gait impairment, they tend to have a steeper slope of progression. And we need to take that into account as we're choosing a great treatment for folks with Parkinson's disease. Another issue that tends to vary greatly between people with Parkinson's is the response to medication and onset of involuntary dyskinetic movements. Some of you, or most of you, probably heard that some people with Parkinson's, actually many as the disease progresses, develop involuntary kind of squirmy movements that we call dyskinesias in response to dopaminergic medication. But not everybody does. So some folks never have that problem. So that's obviously, a big difference between these two groups. Some people with PD have a lot of problems and frustrations with cognitive issues. They might be having difficulties multitasking, forgetting things. They call it memory trouble. And other folks will never. So again, huge difference. Some people are very sensitive to medication again and develop visual hallucinations in response to dopamine medicines. Other people are on high doses and never hallucinate. So we can't just treat everybody with the same medicine and think that we're going to make a great difference. We need to really customize the medication choice depending on what your Parkinson looks like, and also dependent on what you want us to treat you with. There might be a person that I'm seeing today who's not bothered by their tremor at all. Am I going to push a strong tremor treatment on this person? No, that would be wrong. It is not their priority. Their priority might be sleep or walking or balance. So we really need to listen and make sure we're addressing and customizing the treatment to what the Parkinson looks like and what the person with Parkinson wants. This slide is here to essentially impress you how much progress has been made in the last 200 years that us as neurologists have been working on Parkinson's disease. So if you look back, 1817 is when this illness was first described. And here, over 200 years later, in 2021, we're getting so sophisticated in understanding the disorder. We've brought about all these new therapies that you don't need to read over, but you need to be impressed by how many advances have been made. Took about 150 years before levodopa was discovered in the history of Parkinson's disease. But then the progress just started happening quicker and quicker. 30 years later, we had already brain surgery available for Parkinson's, deep brain stimulation. And now we're getting so sophisticated as Parkinson's scientists that we are thinking about the genetic aspects of Parkinson's. Why is this person having a tremor predominant form? Well, maybe they have a specific gene that drives their tremor. And can we maybe customize their treatment to that particular underlying gene defect and make it very much specific to their PD? So very exciting to be part of that. Now, let's get started with getting concrete and talking about treatment. So what is the current state of treating Parkinson's, kind of the conservative or old school? Who are the old players? All of you have heard that carbidopa, levodopa is the gold standard for treating Parkinson's disease. Makes a lot of sense. Parkinson's gives you a lack of dopamine at the brain level, and as clinicians, we have the opportunity to give you back dopamine in the form of levodopa, which is great. It's cheap, it's generic, it works. It can reduce disability, prolong life, which is nice, longer life expectancy. So great advantages for levodopa. However, levodopa is not for everyone. And luckily, we have many alternatives already on the shelf today. This is not the new medicine category. They're dopamine agonists. They're what we call MAOB inhibitors, amantadine for those who have a lot of tremor, trihexyphenidyl artane, again, for those who have a lot of tremor. And if people don't get along with any of these meds, or if they have medicine complications, motor fluctuations, we have a great surgical treatment available, deep brain stimulation. So that's fantastic. So we can, control symptoms to a great degree, enhance quality of life, reduce mortality. But there are some shortcomings of these conventional medications. For example, medicines have side effects. Well, that's not specific to Parkinson's, but what is specific to Parkinson's is a special side effect profile, that I should say, that is called on and off time or motor fluctuations. Again, many of you familiar with this concept. Your medicine might be working great for a short period of time, but then it might trail off and you get slower again. You can't walk as well. You feel like you have no energy. And then you take the next pill and maybe that overshoots and you get these dyskinetic movements that you were discussing earlier. So that's what we call motor fluctuations that are induced by dopaminergic medication. Some medicines might make you sleepy or dizzy or constipated. You might feel that you're cognitively not as sharp on certain other meds, or you might develop visual hallucinations. And then the deep brain stimulation, while being a terrific treatment for most people, still it's brain surgery. It carries a risk with it. We should not take it lighthearted. So there are certainly shortcomings. And another important shortcoming is that the medicines I've mentioned so far only address motor symptoms of Parkinson's disease. How about the many non-motor symptoms? We already said cognitive impairment, but also depression, anxiety, low blood pressure, dizziness, hallucinations. There's so many important non-motor symptoms that the old players, the conventional medications, not address. Therefore, there's a set of challenges for us as clinicians to do better. And here again is a slide that delivers good news. Of all the problem areas that I said previously we didn't have great treatments for, Offtime, dyskinesia, psychosis, low blood pressure, drooling, needing less invasive surgical approaches, all these solutions have been found that I displayed on the slide on the other side just in the recent years. So no more waiting 200 more years. These are the new medicines and the new surgical approaches that are available today. So the first group of medicines that I will discuss under the section New Medicines addresses the off time. So just to make sure we're all on the same page, what do we mean with this? What we mean is that if you take a medicine that contains dopamine, let's just say levodopa, to keep it simple, you have a sudden rise in the blood level of that medicine, but after about 3 hours or so, that medicine comes down in your system and you might be slower again, stiffer, you might not be able to walk as well. All right. So that issue is not a big issue early on. Early on, you're in the green zone, even though your blood level might fluctuate. You're walking well all the time. That's great. However, as Parkinson's advances and you might lose the ability to store some of the levodopa and your dopamine receptors get a little bit more finicky and not so easy to deal with, what you will develop, if you fall into this group of folks who develop it, is a period where your medicine does not work well. That is called off time. Can lead to falls, can lead to feeling bad. You can even feel anxious and antsy and pace. It's not a good feeling. And that is what we call off state. And that off state increases as Parkinson's advances. It's displayed in blue on this slide. So there are new medicines that are helping off time. There are new ways to deliver levodopa that are not your traditional yellow Sinemet. There are add-ons to levodopa, and then there are rescue medicines that can rescue you out of an off period. So let's start with discussing something that was actually approved in 2015, which is an extended release capsule of levodopa. And you might argue, well, this is supposed to be about new medicines. Why are we including something that's 7 years old? Well, let me tell you what. I continue to be impressed when I talk to people in the office who live with Parkinson's, that many of them have never heard about this. So if you're in this category of you've never heard that there is an extended release capsule called Rytary that essentially kicks in rather quickly, but then lasts much longer than the conventional yellow Sinemet form of levodopa, then this slide is for you. This is an advancement that has helped many people deal with off time. The good thing is that this is still levodopa. So if you are somebody who tolerates this well, it just doesn't last you long enough. We're not introducing a new medication or a new side effect. We're just giving it to you in a different format where, you know, the pharmaceutical industry has done a good job re-engineering an old drug. And with the way of giving this, you could potentially reduce the frequency at which you take levodopa. A lot of my patients take it every 3 hours. Maybe now you can take it every 5 hours, and you would have less of that off time. What you need to know is that this is not the same levodopa as the other levodopa. In other words, the milligrams are not the same. If you take 100 milligram of one, it's not 100 milligrams of the other. So be really careful and follow the instructions of your doctor when you're crossing over to this new formulation, if that is what your doctor recommends. But that's a really nice re-engineered way of giving people levodopa. Here's another set of news that really, again, is not brand new as of yesterday, but again, is new enough that many people have not heard about. There's another way, a very, very clever way of giving levodopa continuously as an infusion in a pump system that we refer to as Duopa, which is the brand name of the levodopa intestinal gel that is given to people in form of a pump. Why would we even think about that? Well, we said we want to avoid the fluctuations, right, that are coming from the blood levels of levodopa and finally the brain levels of levodopa, right, be going up and down. If you can imagine, if you place a medication pump for any medicine and you program it such that it delivers small quantities of the medicines at all times, you're cutting out the fluctuations. That is very clever. That's very smart. One other smart thing about this therapy is that it delivers the medicine directly into the gut. Some of people living with Parkinson's disease have a rather slow emptying of their gut. They might have gastroparesis and their stomach never empties out, and their medicine gets very poorly absorbed. They might have dose failures. They take a dose of Cinemet, nothing happens. They take the next dose, something happens. It can be quite unpredictable. So if you put the medicine through a medication port, it's called a PEG-J tube, directly into first the stomach, but then going on into the intestine and putting it directly into the jejunum, then it can be absorbed bypassing the stomach. And the blood level will be the same throughout the day. So very nice. People really have much less off time. I often see a reduction of the involuntary dyskinesias also. Patients carry this pump in either a fanny pack or a vest as displayed in the slide on the images below the stomach image. The issue that people have with this, it's still a pump you have to carry around. It's a little bit clunky. And it's clunky because that gel that contains the levodopa gel is kind of thick. So the pump has to do a lot of work to pump it through that tube to get into the intestinal tract. That's why it's not microscopically small. However, in a clinical research study that's being conducted at many centers nationwide right now, we're researching a much smaller form of the pump that is delivering the medicine under the skin through a microneedle system. That might be something that's more appetizing to some people. But let me tell you that if you're not about convenience, but about efficacy, this might be something you could ask your doctor about. Quite effective. Now, these last two that I mentioned were essentially new ways to deliver levodopa. However, we can also continue with what's generally working, namely your old player levodopa, and just add medications on that are newly invented medicines that make the levodopa last longer in your system. So here are three examples: Zofinamide, Xadago, Opicapone, Ongentys, and Istradefylline, or called Neurons. So these medicines all have in common that we give them once a day. You essentially establish a blood level where their action is continuously there. And the first two have in common, the Xadago and the Ongentys, that they make the levodopa hang around longer. They inhibit its elimination through two different mechanisms, one very similar to Azilect or Rasagiline, and the other one similar to Comten or Entacapone. So, so that's one way of dealing with off time, is to make sure the levodopa doesn't get out the door too quickly, make it hang around longer. And the Istradefylline Neurons is a little bit different. It does not work on eliminating levodopa slower. What it does, it works on a receptor called the adenosine A2A receptor, and it blocks that receptor. And by blocking it, it almost liberates the action of levodopa. So levodopa can act more freely. Now, these three medicines, you will probably find that at least one of them might be reducing your off time quite successfully. However, they all have the potential to worsen dyskinesias. So if you think about Parkinson's, and we looked at a slide that showed the ondulation of the levodopa levels, anytime you push it higher by not eliminating it or stimulating it, you can overshoot into dyskinesia. So that's kind of a downside. And then here is an add-on that I wanted to mention to you that does not have the dyskinesia downside, so it's good to know about. This add-on is called amantadine extended release, and it is marketed under the name of Gocavry. This is a capsule format that you take once daily at bedtime. Again, establishes a blood level, hangs around all day, and it is approved as an add-on to levodopa to address off periods. A lot of you, or many of you, might have heard of regular amantadine, generic amantadine. It kind of does that as well. It's just not FDA approved for treating off time, but it will reduce off time to some extent. This is a longer lasting, more stable blood level version of this. And like I said, the advantage is that it will not increase dyskinesia. As a matter of fact, as we will discuss in a few minutes, it is also FDA approved to treat dyskinesias. So it might be good to know about. However, downside, can induce constipation, can worsen cognition slightly, and in those predisposed to hallucinations, it can worsen hallucinations. So unfortunately, There are downsides with this as well. Now, I mentioned a little bit ago that there's also ways to use rescue medicines if you're in an off period. So we're still discussing new medicines for off periods. So sometimes you're just about 45 minutes or 30 minutes from taking your next dose anyway, but you got to go somewhere, or you're in the middle of a meeting or something like that, giving a lecture to people about Parkinson's disease, and you want something to bridge until your next dose is due. There's two ways now of newly approved medicines that could help you with that. One is an inhaler, levodopa inhalation powder, marketed under the name of Inbrija, and one is a sublingual film of apomorphine, marketed as Kinmobi. The inhaler, you will hold the inhaler that you can see in this picture. You will load a capsule of levodopa in there. You will inhale it. You will load another capsule. You will inhale it again. And it takes about 10 to 20 minutes to kick in. And then it will, in most people, relieve their off time quite successfully until the next dose of levodopa is taken anyway. Downsides might be potentially, not for everybody, the mechanics of loading that capsule into the inhaler. If you're in an off period and your hands don't work, that might be a little tricky, but you might have a care partner who helps with that. And it might be that the powder makes you cough. So we were involved in the initial trial of bringing this to market at my institution, and we had some people who were really coughing hard, did not like that. Others never coughed. So very individual again, but great in the sense that it is still levodopa. You're not exposing your body to anything that you're not used to, and it's just there as needed. You don't have to take it all the time, only if your levodopa runs short a little bit before the next dose is due. So that's one option. Option number two, relatively newly approved, is the sublingual under the tongue strip of apomorphine. You see it depicted in this picture here. The lady holds a strip, places it under the tongue. It will dissolve. You don't have to actively swallow it. You can use this again as needed for off periods. Takes about the same amount of time to kick in as the inhaler, 10 to 20 minutes. The issue here that's a little bit specific to this drug is that it can cause severe nausea. And because we know that, as doctors, we usually prescribe an anti-nausea pill that you would take every day, essentially as a prophylaxis, even on days where you don't take the Kinmobi for the first few months of using it, so that if you take it, you don't have nausea. So you're committing yourself to this anti-nausea regimen until you're used to it. Number two, you should initiate this treatment in the doctor's office when you use it for the first time. The reason is that it can induce an episode of low blood pressure. And we don't want you to have low blood pressure, feel woozy and dizzy, or pass out at home. It is much better to do that in the doctor's office if you have to at all. But other than that, if it's done correctly, it's working really well as well. So 2 new medicines for rescue therapy of off time. Now we are going to the chapter of dyskinesias, which, remember, that is the red zone in this curve. This is the overshooting. When you have too much levodopa in your system, you're taking your pills, they overshoot, you're getting maybe too wiggly, you start shifting, you look antsy, you might have curling of your arm, or your foot might turn in. That's what we call dyskinesia. And until recently, we really had no FDA-approved treatment for that. Dyskinesias are uncommon in early Parkinson's disease. You see on this slide that in the first year or so, it is really not a common problem. And even after 2 years, it is not a common problem. But after about 5 years, about half of folks with Parkinson's are starting to see some dyskinesias, and in advanced Parkinson's disease, about 90% of people with advanced PD have some degree of dyskinesia. Now, this might be very mild and might just be a little neck twist. And, if you have that, you don't bother. That's fine. But some people get so dyskinetic that they slide out of their chair when they want to rest. And obviously, we need to take action. Or their foot is turning in and they start tripping over it. We need to take action. So what action do we take? Well, first of all, it's pretty simplistic. We don't need any new medicine for that. We might want to reduce the overall medication burden because this is an overshoot phenomenon, right? So your doctor might try to bring your medicine down, but that might not work because then you might have some off time. So if it doesn't work, that's when we need to look for medication to add on to treat the actual dyskinesia. There are two options. As doctors, we can use generic amantadine. It's been around since essentially the era of levodopa. We give that first once a day, then twice a day, maybe 3 times a day, but it has to be taken multiple times a day. It is not FDA approved for treating dyskinesia. Or we can go to the new drug, Gocavry, extended release amantadine that you take once at bedtime, which I already mentioned is also a treatment of off time, right? So potentially you could treat 2 problems with 1 drug. You could reduce dyskinesias and also get less off time during the day. So amantadine, again, is an option for treating dyskinesia. I already mentioned, can worsen constipation, can worsen cognition, can worsen hallucinations. However, if you don't have any of those issues, then this might be a good choice to discuss with your doctor. So the motor fluctuations we discussed and what to do about those. Now let's talk about some non-motor symptoms. Like I said, until just really a short time ago, there were no treatments for non-motor symptoms of Parkinson's disease. One non-motor symptom that I think is extremely important to discuss is that of psychosis, visual hallucinations. It's sometimes something that people don't like to talk about or don't talk about a lot with their doctor. They feel it's a little bit embarrassing, but really it is important to bring up because it can be so disturbing to you. It can be disturbing to your spouse. It is a common complication of Parkinson's disease. It can occur in 3 settings. You could have Parkinson's disease and an acute medical illness like a urinary tract infection or something like that, COVID, and that medical illness might lower your threshold for developing hallucinations, and you might see images, people, shadows, things like that. Hallucinations can be the result of certain Parkinson medicines. Pretty much all Parkinson medicines or too much Parkinson medication, right? So we need to bring that up to the doctor so the doctor could potentially lower your Parkinson med or eliminate some of the biggest offenders. Or hallucinations, third, can be a sign that your cognitive status is worsening. Maybe you're developing mild cognitive impairment or even beginning dementia. And in that case, hallucinations become more common. Initially, they're not very bothersome. They might just be seeing a shadow or a person every now and then or an animal. But it has been shown in research that over time, if they're not treated or not addressed, these hallucinations will become more threatening to the person who's experiencing them. There might be some delusional thinking that's setting in, and we need to know that hallucinations are the most common reason for a person with Parkinson's disease to be admitted to a nursing home. So we take this very seriously. Until recently, no medicine was approved by the FDA to treat Parkinson hallucination. Now we have one. It's called pimavanserin, Nuplazid. This is the first in class to be approved for this indication. We also have 2 other ones that as doctors we use, even though they're not approved for Parkinson's psychosis, quetiapine, Seroquel, and clozapine, also referred to as Clozaril. The new one, which is actually approved, the pimavanserin, is usually quite well tolerated, whereas the other ones that we had to be using because there wasn't an approved one, the Seroquel and the Clozaril, they often lower blood pressure. They can make people quite sleepy. So the pimavanserin usually does not lower blood pressure, does not make you sleepy, but it takes quite a number of weeks to get in your system and to help. It takes about 4 to 6 weeks. So if you can imagine if your spouse is calling into the doctor in a little bit of a crisis because they're concerned about you because you're seeing things, and then the doctor prescribes something that in 6 weeks might make you feel better, that might be a little bit of a delayed response. So hopefully either we should as doctors initiate this earlier or think about other ways to treat the psychosis better. But it's so good to know that there is one approved treatment for this condition, but also the other 2 that we had been using are working quite well as well. Another non-motor symptom that I take quite seriously as a physician specializing in Parkinson's disease is that of what we refer to as orthostatic hypotension. What does that mean? It means that your blood pressure might suddenly drop when you are changing from a seated position to a stand-up position, or from laying supine in bed to getting up out of bed. You might feel a little woozy, a little dizzy, or you might actually pass out. And if you look at emergency room admissions for people with PD, hallucinations and syncope, passing out, are the two most common ones. So we definitely need to address that. And again, until this new treatment came about that was approved recently, we had no FDA-approved treatment for orthostatic hypotension and Parkinson's disease. Even though it is common, it affects about half of folks with Parkinson's disease. But now we do. It's called DroxyDopa or Northera. So as a clinician, again, when you come to me with this symptom of I'm feeling dizzy and my blood pressure is low, it could be just due to having Parkinson's, but it could also be induced by one of your Parkinson meds. So it is my job to look at your med list, see if there is anything I need to take away, or maybe you're taking 3 medicines for high blood pressure that you really used to need, but you don't need anymore because your blood pressure is now lower. We need to eliminate those. And then we should consider advising you to increase hydration, maybe drink some Gatorade, increase your salt intake, elevate the head of your bed, all non-pharmacy measures to help you with low blood pressure. But if all of that is not helping, like I said, there is now one medicine that's approved for treating this situation, and that is called DroxyDopa or Northera. It is after you take that pill, metabolized to norepinephrine, which constricts your blood vessels and then pushes your blood pressure up. There are also some that we use that are not approved, but we're using them anyway because they tend to be helpful and work, that are called midodrine and fludrocortisone. But the DroxyDopa is actually approved. The downside of all 3 of those, the old ones, the midodrine, fludrocortisone, and the new one, the DroxyDopa, is that if your blood pressure goes too high, that can be risky as well. Could be inducing heart attack, stroke, or something like that. So that's not good. So it needs to be handled very carefully. Usually we don't want to give it late at night because your blood pressure tends to increase naturally when you lay down overnight. So used sparingly, though, they could keep you from passing out and keep you safe. Next topic. So we're talking about a lot of stuff, covering lots of ground here, is that of drooling or sialorrhea. Again, it is sometimes not the favorite subject for some people to talk about with a doctor, but drooling can be quite annoying. It is also hidden very well right now because we all wear a mask all the time, but you might see that your mask is actually soaked after you take it off, or your pillow is wet, or you have some saliva stains on your shirt. Can be socially embarrassing. Your spouse might not like to wash it all the time. So we need to often address the sialorrhea and the drooling. We do that in a number of ways, but until recently, again, we didn't have an FDA-approved treatment for sialorrhea with Parkinson's, but again, now we do. There are some medicines that make sialorrhea worse with Parkinson's, and again, that's on me. My job is to look over your med list and figure out which one could be offensive. But if you really need an actual treatment for sialorrhea, what we find works best is injecting a medicine, either Xeomin or Myoblock. These are medicines that are closely related to Botox, actually. So they are a form of a botulinum toxin that binds to the saliva glands and reduces saliva flow in Parkinson's disease. Interestingly, the drooling is not caused by a saliva overproduction. It's actually caused by people with Parkinson's not swallowing frequently enough. But nonetheless, if I downregulate your saliva production, you're not going to drool as much. And so the way this is given, the Xeomin that was recently approved, is with a tiny, tiny needle, I can inject some of the Xeomin right into your 2 saliva glands, the parotid gland and your submandibular gland. These sit, luckily, right under the skin. So it's a little prick in 2 spots on one side of your face, and again, 2 pricks on the other side. Lasts about 3 to 4 months, and it does not make you constipated, drowsy, dizzy, or give you low blood pressure because it stays right where we put it. So that's a pretty neat advancement. You just need to really tell your doctor that this is bothering you so they can act on it. And finally, to conclude this talk, this is not a new medicine for Parkinson's disease, but it's a new way of treating some symptoms of Parkinson's disease surgically. I had already told you that deep brain stimulation is an treatment that has been available for close to 20 years to treat some forms of Parkinson's disease quite successfully. We use the deep brain stimulation, the old method essentially, to treat two scenarios in Parkinson's, either refractory tremors, so people who, despite their doctor's best attempt, still have a lot of shaking, and we use it to treat the motor fluctuations, the on and off time. So if, despite the doctor's best attempt of giving you long-lasting levodopa and all these add-ons that eliminate off time, you're still having off time and you're still having levodopa, you will likely talk to your doctor about deep brain stimulation. And it's a really wonderful treatment. It does require brain surgery, though. It's essentially implanting a pacemaker into an area of the brain that is relevant to Parkinson's disease. The great things are that it can be customized over time. As your Parkinson's progresses, we can adjust it and so on and so forth. But it's, invasive brain surgery. So neuroscientists have thought about that and came up with a newer surgical technique that many of my patients ask me about that's called focused ultrasound. And the issue here is that the surgeon does not have to cut an opening into the brain to achieve control of refractory tremors in Parkinson's disease. So the focused ultrasound is a new way to address refractory tremor with PD. So how does this work? And is this really entirely non-invasive? It is not non-invasive. The non-invasive part is that we don't have to cut into the brain to get there and place, hardware or something. But you need to understand is that we're using ultrasound here to burn a lesion into the brain, a little bit similar to what a laser would do. We all know about lasers and, they're really hot and they burn a lesion. Here, we have thousands of ultrasound waves coming together in a place that's smaller than a millimeter. And if they all come together in that place, it creates a lesion because it creates heat. So it's burning a lesion into the brain. You can call that non-invasive. You could also call it invasive, depending on your choice of vocabulary. I just want you to understand that it's not, taking candy. It's not. However, you don't have to cut into the skull, shave the head extensively, and so on and so forth. So what happens is you will lay on a table that slides in and out of an MRI machine, and you will be put into a head frame. And you can see it on the picture here. This looks like an astronaut or something. I don't know. I've never been in a spacecraft, but your head is fixated in a head frame because you cannot move when the surgeon is bringing these ultrasound waves on, right? And then you're also wearing a water-filled helmet that contains the ultrasound transmitters. Your head is numb, so you don't feel the pressure as much as all these gadgets. And you're going in and out of this MRI machine because the neurosurgeon will look at your brain while they're centering the waves into the area where they want to put that lesion. So it's done under imaging control. Once the surgeon finds the right spot, they will bring on that heat and that lesion will be created. Takes about 3 hours all in all to do. Some have you stay the night, some have you go home immediately after. So it is usually done on one side of the brain. So if your right hand shakes really bad, they would do it on your left side. It cannot be done on both sides right now. Maybe in a few years as science advances, but right now it would be one side of the brain and the target would be tremor. What are the advantages and disadvantages? Advantage, we don't have to cut into the brain. I already said that. So this is an advantage for people who are, for example, on blood thinners and cannot stop them for a prolonged period of time before an invasive surgical procedure. And it might mean that they're not a DBS candidate, but they could be a candidate for this. There is minimal downtime after the procedure. You go home the same day or the next day. The effect is immediate. So you get what you get. Immediate gratification. And then there is no adjustments necessary. It's one and done. That can be an advantage. You can also look at that as a disadvantage, because if you don't like the effect that was immediate, well, that's the effect you have. It can't be adjusted. So look at that as an advantage or a disadvantage, depending on your philosophy. I already said we can only treat one side of the brain. So if you have terrible tremor on both sides, that might not be very helpful. But if it's really your dominant hand you're worried about, then this might be a good solution. I already said this lesion is irreversible. You get what you get. We can't adjust it. And some of the side effects that I need to mention are especially related to walking and balance. So if you look at the studies and potential side effects on folks who've done this, some end up with unsteady gait. And obviously that might be an issue for you anyway, as you have Parkinson's disease. So if you do have that issue, this might not be the best solution for you. However, if you have no issue with walking and balance, you're on a blood thinner, you can't have DBS, this is something to talk about. There are a number of centers now in the country that do this procedure. By far, not every big Parkinson's center does this, but if you go online and Google focused ultrasound, you will find a list of organizations who offer this form of treatment. Fairly new, but much more widely available today than it was just a year or two ago. So we have discussed some terrific advances. I'm really, really positive about this, but there are some shortcomings even of the advances that we just discussed. And the shortcomings mainly are that none of the medicines that we discussed today or that are available on the market today stop or slow disease progression, right? So this is where we need to set the goal for the future. We need to understand the biology of Parkinson's better, maybe understand what genes influenced you to get Parkinson's disease, and then target your Parkinson's disease more specifically with hopefully disease-modifying therapies that will slow or stop the progression of this disorder. I have no disclosures for this talk, and I am very happy to conclude the session now and go to the question and answer portion of it.
Thanks very much, Dr. Hinson. That was a fantastic presentation. Really appreciate you covering a lot of material here that I think that our audience is going to find incredibly useful. And I also appreciate you addressing the elephant in the room, which is what you just talked about was, I think, a lot of great advancements, but we're still short of a cure for that. And it's just a question for you around that. What do you tell people who may ask you that? Thank you for this, but we're dealing with a drug in essence from the 70s. The levodopa, carbidopa is the mainstay. Do you highlight where we've gone with these advances as a way to give people hope? And I think you nicely hit on where we're going next by taking a look at genetics of people with Parkinson's, trying to understand how to improve upon that.
So I think important things to think about, right? So why levodopa when it was, it's as old as me? That's not good. But people were quite clever in the 70s, so we can't take that credit away from them. But I think what we need to understand is the way to get more sophisticated is to understand why somebody got Parkinson's disease and to address it as early as we can. Coming in with levodopa after somebody might have had Parkinson's brewing on the brain for 10 or more years might be just a little bit too late to stop that particular individual from progressing. And that's, I think, something we haven't talked about today is, why don't we have a therapy that delays progression? I think my personal view is that some of that lies in the fact that the changes that occur in the body with Parkinson's disease go on many years before we develop a rest tremor or slowness or stiffness or walking changes, but we can't diagnose them yet. So we're missing the boat on 10 years or so or more of an opportunity to potentially offer a person something that might keep them from ever developing the tremor or addressing this early on. So we need to develop early diagnostic marker before somebody develops a rest tremor.
Yeah, I totally agree. That's something we've heard before, is that Parkinson's, and I think people with PD may inherently know it, that their disease probably was ongoing before they went to see someone like you to say, sorry to say you have Parkinson's disease. We talked a lot about new medications, and I think there's a lot of exciting possibilities. Is there any reason for a person who's diagnosed with Parkinson's to hold off on taking any of these medications? For instance, we talked about Rotari. It's been around for a couple of years, but you still encounter people who haven't heard about it. Do you start people newly diagnosed with levodopa, or do you start with something like Rotari? What's your approach for handling this influx of different approaches to treat people in a plethora of riches, if you will?
Well, you're asking two great questions, right? The first question you asked was, do we even need to treat, right? somebody comes in, they have a resting tremor, they're not particularly bothered by the tremor, they just want to know what this is. Am I going to prescribe anything? I think if the rest tremor, Jim, does not affect them functionally, I would not prescribe anything. I would say that there is no medicine on the shelf that slows down the progression of Parkinson's disease, and we don't just need to reduce tremors for the sake of reducing tremors. We need to have function in mind. I would advise that individual to really make some lifestyle modifications, and most importantly, to start exercising, because we do know from science that exercising intensely, a minimum of 3 days a week, but ideally 5 days a week, 30 to 60 minutes, where your heart rate really goes up and you break a sweat, actually will delay the progression of Parkinson's disease. So while I can't write that prescription, I can counsel the individual with very early PD to consider doing that instead of taking levodopa. But then there might be an individual coming to my practice being newly diagnosed with Parkinson's, and they might be in a job or a situation where they need perfect control of their hand. They might be a court clerk or something like that. Their handwriting is so small, nobody can read it. They can't keep up typing on the job. That's not good. We need to do something now. We can't just say exercise and wait on stopping disease progression. So I would prescribe that individual generic yellow Cinemed levodopa. Early on, we have a lot of storage capability, likely, as we showed on the slide, no on-off fluctuations in the first 5 years of Parkinson's disease. So I believe in keeping it simple and prescribing something that's very predictable. You have to take it 3 times a day, so it's a little bit inconvenient. But again, Parkinson's is not about convenience, it's about efficacy.
Yeah, I think our audience definitely knows that all too well. There's a lot of the medications you discussed. Some people may not be on. They're on medications that their doctors prescribed. How do people with Parkinson's talk to their doctors about these new medications? When is it time to discuss, to say, I just saw this great webinar by Dr. Hinson. There's some new medications. How do they say, are they right for me, these potential drugs? Or is it, as you point, a specific problem that's trying to be solved?
I think 2 pieces of advice. First of all, if you have Parkinson's disease, my opinion is you should be seeing a movement disorder specialist. It's like having heart disease. You're not going to see your GP about your heart disease or your family doctor. You're going to see a cardiologist, right? Because they know the most about the heart. Movement disorder specialists know the most about Parkinson's disease. We know pretty much nothing about migraines and back pain. That's the general neurologists are great about that stuff, but please go ahead and seek out a movement disorders consultation. And when you talk to the movement disorder specialist, I would bring up exactly what you said. I would say, look, this is the symptom that bothers me the most. I really don't like that I'm sleepy all day, or I don't like that, my hand shakes when I want to write. This is what I want to address. So tell the doctor what symptom matters. And then, yes, you might bring up the treatments you've heard about and ask, is this right for me? It might not be right for you for another reason, but I would bring it. I don't think any doctor is ever offended by patients asking great questions, and we're used to patients asking very sophisticated, great questions.
Yeah, that's a really good point. Our well-educated community, well-educated patients can be their best advocate at times. This is a question that I often hear, and I think you touched on it a little bit when talking about when to prescribe, levodopa, and just want to help disabuse people of this idea that taking levodopa early may lead to, it's often has been viewed in the past as the big gun and needs to be saved for when it's really needed. But I think you just said if someone needs it to help do their job better, or to do other things like that, it's probably time to do so. There's no real drawback or to take the medications at a little different time based upon their needs than later, for instance. It's not going to lead to, they're going to develop the dyskinesias so much earlier than someone who waited a long time to take medications, for instance. Is that accurate?
So what we want to tell people about levodopa is, if you start levodopa today or in 2 years from now, the progression of your Parkinson's will not be accelerated by the time at which you started taking levodopa. You also don't get immune to levodopa. Some of my patients think that if they started today, it will quit working for them 5 years down the road. No, that is not the case. Their Parkinson's might progress, and therefore they might need more levodopa down the road, but their Parkinson's progresses because their Parkinson's progresses, and not because they're taking levodopa. I think important to know is if I have disabling symptoms so that I need symptomatic treatment, I need to take what works best. And if that, in my doctor's judgment, is levodopa, that is a very good choice. If you think about side effects and what matters most to patients is levodopa really has the least side effects. So if you compare that to a dopamine agonist such as ropinirole or pramipexole or tigatine, those medicines can oftentimes lower blood pressure, cause syncope, cause hallucinations, cause lower extremity swelling, cause sleepiness. That's not good. And so levodopa doesn't do that as much, as a matter of fact, much less of that. And so that's why we know it's very effective, and we know if we use it sparingly, we can use it early on. But this is an important other point. You don't want to go to the doctor and the doctor doubles your dose every week. That would be entirely wrong. Conservatively using levodopa is usually the right thing to do, with the emphasis on conservatively, because if you don't, that's when you induce dyskinesia. But you can do that with any Parkinson drug. It's not specific to levodopa. I can give you high doses of another drug, you get dyskinetic as well. But I want people to stay on a conservative dose that's enough to take the edge off the symptoms where they start feeling well and feeling themselves again.
Yeah, I think that's a really good point. And I think goes back to your first point about seeing an expert who can really help manage their medications properly. Timing for medication is so important with Parkinson's disease. It seems like some of these medications will help with that and help for people who aren't able to meet those timing needs. Would you agree? I mean, like, what would you, do you see in your practice prescribing a lot of these rescue medications for people? Or do you just say, you need to work harder to take your medications on time? I mean, what's your approach? Is it both?
Timing comes first. I think, keeping things simple is always a good principle in medicine. So if you take levodopa on a 4-hour basis, but it only lasts you 3 hours, well, how about taking smaller doses more frequently? And again, we would just go to a 3-hour schedule, right? So the brain tells us what the brain needs. But at some point, these little clever adjustments are just not good enough. And that's when we're thinking about an add-on versus a rescue. Now, how do we decide whether an add-on is better or a rescue? I think there's an important difference. If there's off time between every single one of the doses, you don't want to be inhaling and rescuing all the time. You need something long-acting to really take that off time away all day long. And so a once daily long-acting add-on might be much, much smarter. If the off time is unpredictable and only happens every 3 days or so at whatever time, very unpredictable, that's when a rescue medicine is much better, because you don't want to expose somebody to something every day if they don't have that problem every day. So that's how I choose my add-on.
It's interesting. It sounds very similar to like asthma approach, where people are on regular medications and then have this, well, here in the case of another inhaler, for the occasional time that their medications don't work as planned. New medications are fantastic, but that often means they're not generic. And so cost sometimes is going to be an issue. How do you advise patients on how to tackle these cost issues with insurance, or is that something that's really kind of beyond what you do as a clinician in your practice, so
Great
that
point,
they can take advantage of this?
Because that can limit our use of these. So, number of points. If you're a veteran, the VA has all of these new medicines available in their pharmacies. Some of them might be not formulary, but your doctor can get any of these medicines to you for no cost or your small copay. So that's good to know for the veterans. Ask the VA. Second, if you have either Medicare or private insurance, we can first give you samples, right? So if I give you a rescue inhaler, you have no idea if the stuff even works for you. I can give you a month's supply of trying a rescue inhaler before we go into asking your insurance to approve it. Two things about that. A, you know if it's worth it or not. And second, if you do know it's worth it, it's a good argument for me when I write you a letter of support that this is helpful for you. And that brings me to the next point. Your doctor usually, if they write a why explanation, why you need this medicine, can reduce your copay, bring it from 3rd tier to 2nd tier, or even make it at all available to you. Third, there are associations such as the PAN Association, PAN, all capitalized, that support people with Parkinson's disease who can't afford their meds but have to take these medicines. And so if you work at with a doctor, for example, of a Parkinson Foundation Center of Excellence that is supported by the Parkinson Foundation, or even ask the Parkinson Foundation how to get in touch with the PAN Foundation, that can often significantly help with the cost. There should not be a Parkinson patient who needs a medicine and then can't get that medicine. So in most instances, I would say 95% of the time, if I put in the work to help you, I can get you this stuff in an affordable manner. But then some people fall short, and that's sad enough, but that's the minority of patients.
Yeah, well, I think Dr. Hinson will leave it there. A fantastic presentation, lots of information to take in. I certainly appreciate it. I want to thank our audience on Zoom, as well as on Facebook for listening in today. And also want to thank our sponsors, Genentech and Kyowa Kernan, for their support of our expert briefing. We've completed 2, as I've said, expert briefings. We've got 4 more to go. I'm excited about what's coming in December. Great title, The Skinny on Skin and Bone Health in Parkinson's. It's going to be a great topic, tying into ways about how bone health can be really important for people with Parkinson's disease as well. And then, resources and support for people with Parkinson's are here. We have a number of them that are available. Dr. Hinson is at one of our centers of excellence, which is one of our great resources that we make available to people with Parkinson's. But for those who can't, we have aware and care packages, we have podcasts, we have an extensive library of materials as well. In addition to our expert briefings, which we have today, we also have a regular schedule of PD Health at Home webinars to help people with Parkinson's around mindfulness, fitness, and et cetera. And just also to highlight our PD Generation initiative, Medical University of South Carolina is one of our referral sites. We're working very hard to reach out to as many people with Parkinson's as possible to offer this free genetic testing and counseling. Again, as Dr. Hinson suggested, that could really be a difference as we move forward with next generation therapies. Also, we're here for you. We've got our website, which is available, as well as our helpline. So you can email or even call 1-800-4PD-INFO as part of that. And then before you go, I want to just emphasize how important your feedback is for our success in this webinar. We're always taking a look at what people have to say. And as I've said, we work very hard to work with you, a Parkinson's community, to ensure that what we're doing matters to you. So please, when this webinar ends, you'll open up another browser window will appear and give you an opportunity to give us the feedback live on how you thought today's presentation went. And we incorporate that, as I said, again, to improve our expert briefings as we move forward. With that, I want to thank everyone and have everyone, wish everyone a good day. And thanks again to Dr. Hinson. Bye-bye.